Oh, thanks.
Yeah. So it gives me great pleasure to introduce Prof. Alex Brown, who is one of Australia's. He's a frontier man, really. He's paved the path for many of us in Aboriginal health research. He's an Aboriginal man from the south coast of New South Wales. Him and his sister pioneers in Aboriginal health research. They're both medical doctors, Naira Brown and Alex Brown. Not about Naira, I'll stop talking about your sister now. But Alex is really, has been a role model to many. He's been a role model to myself. He's I first met Alex when we were working in Alice Springs, probably in 1999 or 2000 or something. And Alex was a young, fresh doctor, come up to run the Centre for Disease Control in Alice Springs, and we've had many years of collaboration. I previously worked at Samari in Adelaide, which he was my boss then, and he's now with the Telephone Kids Institute and the ANU, and he's been up for a conference this week at the Communicable Disease Immunisation Conference, and just done a plenary this morning, so you always feel a bit deflated after a plenary, but hopefully he's got enough energy to have a chat with us today and share some reflections about his research and what he's up to these days around genomics and genomic medicine. So thanks everyone for coming, and thank you, Alex, for attending and sharing some time with us. I know you're going to jump on the plane straight after this, so thank you.
Thanks, James. Really lovely things to say, and James and I do go back a fair way, and we've like to think we've been a big part of each other's work and life for the last almost 25 years. So it's great to see you guys. Great pleasure to be here. I did just give a talk at the Communicable Disease and Immunisation Conference. It was a very passive-aggressive talk from me. So I was basically giving it to them. They're having all of these conversations about establishing an Australian Centre for Disease Control, and haven't actually had a conversation with Aboriginal and Torres Strait Islander people yet. And it's just beggars belief that in the context of a One Health agenda, which is about human, environmental and animal health, that they wouldn't talk to black folk. It's just fucking insane. So, sorry, I did swear at the plenary. I approached it as if I was writing a letter to the Australian Centre for Disease Control, and at the end I had a PS, which was "Don't fuck it up." So, I don't know how it went down. Time will tell. Look, it's a great privilege to be here in Meanjin, and I really pay my respects to the traditional custodians of the land here. I'm coming to you really from Ghana country, but I'm originally from the south coast of New South Wales, so you and more. So basically from Sydney down to the border with Victoria is all my Mods country. So anyway, what I thought I'd give you guys a talk on is probably some very recent developments in trying to empower communities in them making their own decisions about being involved in genomics and genomics medicine for themselves. And that's an enormous challenge. I'll take you through sort of some of the things we're doing. And if there's any way we can find ways to work together, we'd certainly love to. Next slide, please. Sorry about the imagery here, but many of you will know that the history of science and scientific endeavour in this country is shrouded in some pretty uncomfortable truths. The reality is science was used as a weapon against Indigenous people's interests. It was used to tell us that we were somehow not as human as everyone else, that we were a piece of humanity, but not the full bottle. It was used as cover for the lie that was Terra Nullius. So it was a political agenda, and science was used as the key weapon within that system. So it's not surprising that when we want to talk to communities about genomics and genes and what it all means, they're pretty hesitant about it. They don't really trust that conversation, and nor should they, because our history is checkered with a pretty nasty reality of how science and even the construct of how Indigenous you might be has been weaponised and used as a tool of oppression. Next slide, thanks. Probably the other challenge we faced is in Aboriginal health research, certainly in Australia, our expertise is very much in the population health space. So we've got tremendous expertise, as you guys carry here, as really some of the leading proponents of the work that James has pioneered for some time.
Great.
Well, there's something about online.
Okay. Do you want me to keep talking? I can.
Oh, they must be able to see your slides.
Yeah. Okay.
Cool.
Sorry.
So as I mentioned, we've got tremendous skills in Aboriginal health research in this country in population health. It's our special sauce. It's our jam in many ways. The challenge is, how do we tie these two threads together of what precision medicine and genomics, where we look at basically the variation that exists in people's individual genetic architectural blueprint, how that relates to disease, and how do we reconcile that with a few fundamental questions. Population health, we tend to focus on the broader, the collective, the population proper. Unfortunately, in precision medicine, you're pretty much breaking up people into their smallest component parts, their tiniest little threads of DNA sequence as basically letters, which are fundamentally base pairs in someone's DNA. And how do we crack that code? How do we make sense of that code? Does it even consider the broader context within which health and well-being and survival is enabled through your genetic architecture? Precision medicine very much focused on individual patient, their unique variation, and what that means in terms of the treatment that they should get, their risk of developing disease. As it currently stands, about 85% of all genetic research the world over is focused on Europeans. As if no offence to anyone in the room, okay, dudes, we've had enough. It's time to get some brown folk in play. But population health isn't locked into that agenda. It's much more interested in diversity, populations more broadly. Precision medicine very focused on the gene or the genetic sequence. Whereas in population health, we spend a lot of time thinking about context. What drives or patterns or influences the not just development of disease, but the risk exposures that you're more likely to experience because of the environment you're a part of. Precision medicine very focused on treatment, your drugs, diagnostics. Do you have disease A, B, or C? Whereas in population health, we obsess about prevention, as we should. Then there's questions about, is this an appropriate investment in research or healthcare dollars? Does this reconcile the social determinants of health, which we know are primary drivers of the inequalities that we see in our kids and our communities? And will it help us reduce any of these exposures or fundamental drivers of health inequity? Yes, probably no. So where does it fit in our conversations about the right investment? Is it diverting scarce resources away from what we know really matters to our kids and the next generation? Maybe. So having these conversations has been really, really complicated. Next slide, thanks. So I mentioned before, most of the genomics research that's been done has been on European populations. 80%, I think I said 85%, you can take that all with a grain of salt, it's a shitload. And there are very few diverse, ancestrally diverse communities involved in that work. Now you might say, oh, that's okay, we don't need to be at the table. That's fair enough. However, all of the tools that are now being built for precision medicine are based on this fallacious view that human existence has a European foundation. And so things like risk scores, these things called polygenic risk scores, where you add up every variant that might be in somebody's genome and you calculate a cumulative score of how each of those might contribute to the risk of developing disease. If you apply them to ancestrally diverse people that are not represented in the development of that tool, you get it wrong. So even our chance to use genomic medicine is biased and influenced by our unwillingness to engage with diverse communities. And then the second part to this is, well, if we need to be thinking about the social world and social determinants, can we reconcile those in the context of the practice of genomic medicine and precision medicine? The answer is yes, but we haven't really done it yet. So how can we inform genetics from a social construct? How can we inform social intervention that may have a genomic component to it? We don't know the answer to that, but it's worth considering. Next slide, thanks. You right for me to keep going? Yeah, cool. The way in which the world, the genomics world, responds to this is we'll just include a whole bunch of brown people in our databases. This whole construct of inclusion is now being used as an example of equity. I don't need to tell all of you guys who work in this team or teams that equity involves a lot more than just being included. In fact, it's a necessary step, but it's one on a chain of 100 things you need to do to provide equitable futures for Indigenous or any other population for that matter. So they just think, right, we'll include them, we're cool, equity's done, thanks very much, we'll catch you later. Can I have another $3 billion? We say no. Equity requires much more. Next slide, thanks. So part of the conversation that we're trying to establish with health systems and with communities as well is being really clear about what the actual benefits are or could be of genomics. Because, you know, in Indigenous health research, most of the conversations we have is about risk and benefit. Ethics committees tend to think about risks and benefits more than anything else. Aboriginal people within Aboriginal ethics committees can often see the risks that aren't apparent to researchers. And they'll say, well, no, we've been down this path before, it's been used against us, we've been screwed over, the risk is too great. So this part of the story of risk and benefit is really, really important. Now, what we tend to do as researchers, we're really good at handling this, right? We're very well skilled and equipped with how good our research idea is in terms of benefit. But we don't always negotiate that. We're very good salespeople. We're trained to be really good salespeople. That's how you get grants. But there's challenges within that. We need to negotiate from the community's perspectives as well as ours what benefit really looks like and who gets to decide. So in conversations we're having around what genomic medicine is, we're talking about how genomics could be used as a tool to help confirm, engage, celebrate Indigenous knowledge systems as well. I'll touch on that a little bit later. But we can use genomics to tell our story if we want. We don't have to. We know that we've been here forever. How long does forever need to really be for you, all right? You guys thinking about 2,000 or 3,000 years? Look, try 65,000 years and then, you know, is that long enough? I think it is, but that's another story. There's a lot of work that we need to do that can build trust. We can work out the terms of engagement from communities' perspectives about how we do this stuff. It can clearly be used in the context of making more accurate diagnoses. This is particularly the case with rare diseases. These are usually children suffering from complicated genetic disorders. Genomics and genomic medicine has a very clear and useful purpose there to give families an accurate diagnosis, often an accurate treatment, and can reduce suffering. So it's got a clear pathway in the rare disease context. Our interest, given our interest in chronic disease in particular, how can we use it in the context of precision treatments, precision therapies? What's the right medicine for that right person? Can we predict risk? Who's going to develop heart disease? Who's going to have diabetes in the future? And those people with diabetes, who's going to develop complications? Because that's what communities want to know. They're sick of seeing people end up on dialysis, How do we stop that from happening? Can genomics offer us anything? And the answer may be no, but we don't know that. We clearly need to build a workforce for the future that understands where genomics fits. It's going to be a part of medicine the next 50 years, whether we like it or not. Is the workforce equipped? Do we know the right conversations to have? Do they have the skills? Can we support that? There's a whole raft of stuff around data, data systems, data security, privacy, and Indigenous data sovereignty. Genomics produces enormous volumes of data. We've just started a complete epigenome study of 1,285 Aboriginal people from South Australia. Just starting to produce the data. We anticipate on that 1,200 people, 3,000 petabytes of data just on the epigenome. So I don't even know how much that is. It's like when someone say, hey, we got $1 billion. I'll go, yeah, what's that? I got 100 in my pocket. It's usually 20. I like a lot of stuff. But the data issues, not just in volume and cost and storage and handling and analysis, there's also who controls it. We could use conversations around genomics to think through more equitable policy development in this context, but our ultimate objective is to reduce health inequality. And to get from A to Z here is a complicated journey. Thanks, next slide. So the question is, can precision medicine improve health outcomes? Next. Well, in lots of areas in the context of health and healthcare delivery, it can have an important role to play. It can certainly help in, I've touched on risk prediction. There is evidence that it works. It seems to work mostly in white folk. Why is that? It's white folk are in all of the databases. It can help us, what we would say in medicine, prognosticate, which is a wanky word for I'm going to have trouble. It can predict who's going to respond to certain treatments. It can help you with a patient that you have in front of you with the right genomic testing, work out who's going to go bad, who's going to have a much more difficult course, who do you need to treat more aggressively. And then there's a whole range of stuff around getting the right drugs to the right person, as well as the pharmaceutical industry's interest here. Can they develop new drugs on the basis of genomic medicine? That's why they're so interested in it. Next slide. If we apply that in the context of, say, cancer, which is prime time, this is happening now, patients who have a diagnosis of cancer are having their blood or the tumour profiled, and a comparison between the individual's tumour and the individual's genomic architecture utilised to identify the right therapies. Now, this molecular cancer treatment is working, but the number of people who have that test and have an identifiable target in their genome or the genome of the cancer is only about 50%. And then of that 50%, only about 5% will ever get access to a treatment that will work specifically for their cancer. So there's an enormous gap between finding something you can do something about it and then getting a drug that would actually do something about it based on that molecular profile. But there's clearly opportunities, if we get this right, to improve prevention, to identify genetic markers associated with the development of cancer into the future, to better target treatment, and to improve patient care. But this is all very much hype on most of these markers thus far. There's a lot of work to do to get to making it real. Thanks. Next slide. And what are the challenges we have in the context of, say, cancer? Aboriginal and Torres Strait Islander people in Australia with a diagnosis of cancer aren't just getting no access to genomic medicine, they're getting screwed across the entire care pathway, right? They've got poorer access to the prevention, they're less likely to be diagnosed in a timely fashion, they'll get less access to the best possible therapeutic options, and so our outcomes are worse. And then we've got bigger questions to ask, right? Will precision cancer care provide improved equitable outcomes for our people? We don't know. How can we personalise prevention on the basis of this information? What are the ethical, legal, social, cultural considerations about doing this work and how we apply it? Who's in control? Can we access the stuff that I touched on before? What are the right models of care that can include considerations of genomics within it? What's the right workforce? All questions we don't have answers to. And you say, well, okay, that's cancer, it's playing out, it's not perfect, there's a lot of work to do to make it work. What about the context of, say, cardiovascular disease, which is my area of interest? It's already in play, although it's not being utilised potentially to its full potential. How it works, you get people, the whole population, you profile them in a deep sense. In the genomics world, everyone just adds "ome" onto the end of it. So this is called the deep phenome, so deep phenotyping, just measuring shit in someone. And the way you measure shit is you can do a whole bunch of stuff. You can do clinical, you can collect environmental data, you can do blood tests, you can collect data from imaging, you can do the molecular profiling as well. You get data now from wearables. So I don't wear it because I don't want to know how lazy I've been in a given day. I've got enough reinforcement from my family telling me to get off my ass, but that's another story. You can undertake detailed genomic profiling, whether it be at the gene level, or the epigenetic level, or the proteins that you make, or the metabolites that occur when your body operates. And it's now being used to treat patients, not necessarily just the disease itself. So the good thing in cardiovascular medicine, someone has a heart attack, you give them these 4 things, it happens. Most people get better in some ways. You can now work out not just which patient would respond to the best possible treatment, you can apply that on a larger scale, on a population scale. So the individuals well phenotyped, well phenomed, can give you clues to the right treatment for that population group within an overarching group. It's being used in risk prediction, not so good for non-European populations. It certainly is used in the context of diagnosis, so people with familial or inherited cardiac disorders. There's a dyslipidemia or familial hypercholesterolemia, which is a genetic-based disorder, which means people's cholesterol is like 9 or 10 and doesn't respond particularly well to usual treatment like a statin. In fact, that treatment for familial hypercholesterolemia was found in an African-American family in the US. They had come into hospital for some reason, got a blood test. They found their LDL cholesterol, which is the bad cholesterol, was less than 1. And then they did the genetic testing and identified this mutation which protected them. Pfizer picks it up, makes a monoclonal antibody drug treatment, which now has a $5 billion annual turnover as a drug. This is why pharmaceutical companies are very interested. But the question is, can we now use it to prevent? Maybe. What you'll hear from researchers and cardiovascular people interested in genomics is it can help us with early diagnosis, it can target treatments better, it can help us understand why some patient groups do well and others not so. It should reduce side effects from drugs, it should make the drugs we use more effective, and ultimately it will reduce healthcare costs and improve quality of life. But it's one thing to say all that stuff. The next is to work out how do you actually deliver those benefits, and for whom, and on what environments and what resourcing things. And the question we have as fundamentally public healthy people, can we shift genomics? Can we bend the wheel of genomics to be used in the context of prevention? Right? In primary prevention, that is people who don't have disease, but are exposed to stuff which will increase their chances of developing disease. Can we use genomics to target or understand how to mitigate that exposure? In the context of secondary prevention, people who've got subclinical disease, can we stop it from becoming overt? Can we delay it or stop it altogether at an early stage? And in tertiary prevention, where people have got disease, can we use genomics to improve their outcomes, to reduce progression to complication and end-stage disease development? The answer is probably yes, but we don't know how all the pieces work together. So what are the challenges that we're talking to communities about all of this stuff? They're saying, well, we don't trust. Well, they may trust me, but that's a pretty, that trust is easily lost. Hard to win, easy to lose. That's what we tend to talk about in this sort of community engagement efforts that we're all a part of. People are worried about how it's going to be used against them. The first question I had when we developed this large-scale genomics project in diabetes in South Australia was, will the cops get this? Can they use it? So I then went on a long journey of fighting with the legal team within SAMRI and with the mainstream ethics committee to say that we would never release that information even under subpoena. And they said, well, you'll end up going to jail. I said, well, I'll catch up with all the cousins. Which they didn't think was funny, but thank you for laughing at that. We touched on the history story. Science has never been particularly good to Aboriginal and Torres Strait Islander people's interests. Who's going to access that data? There's questions about having to store it locally or putting it on a cloud. Most communities don't know what a cloud is. What the hell are you talking about? What's this cloud thing? Exploitation. How's it going to be used? Who's taking it? For what purposes? Are you going to be misappropriating more correctly our culture? And how's it going to help our kids? And these are really important questions, all of which we don't have the answers to, but we're trying to work through them together. Thanks, Nelson. And what we tend to always find ourselves in the context of Aboriginal and Torres Strait Islander health in this country is everyone talking about how screwed up we are. The question is, what do we offer? What is it that we have that will be useful to the conduct of research and genomics, for example, into the future? Because the work that we have to do, the questions that our communities are asking, are the same questions that a whole bunch of mainstream communities are asking too, but they've just never felt that they could ask. They sign onto the consent form because they think it's the right thing to do, but they don't never ask what happens to my data. They don't say any of the things that we're raising as concerns, but when we mention it to them, they go, yes, we're worried about that too. So not only is it guidance we can provide to doing things the right way, that could help other communities as well. It's also our ability to understand complexity and context, which a lot of white mainstream researchers struggle with. We spend our entire lives thinking about context. It's not just the rate of disease, it's what happens that disease, what drives that disease, how we mitigate that impact. Thanks. So what are we doing? Well, I mentioned sort of in part, three sort of major things. One is the group that I lead, based now largely out of Adelaide, but we have people in Melbourne, we have people in Perth, and we have people in Sydney. There's an Indigenous Genomics group. We're very interested in working with communities about how to talk about and understand what genomics is together. We feel strongly that there is an opportunity to understand what Aboriginal people understand about kinship and how this might relate to genomics. I'll touch on that in a second, I think. We've got a job to do to develop the national resources that can be used to make sure genomics is used for the benefit for our communities. Whether that's developing a variant library where you store anonymised data of different variation in people's genetic picture, so that when a clinician has a child in front of them and says, we're not sure if this is an inherited genetic disorder causing this trouble, we can say, well, we see this variant all the time in Aboriginal people, that's not the cause. They can get on to working out what might be. As well as reference genomes and biobanking. Reference genome is basically a standard jig, for those of you who might build things, a reference template that represents the sort of usual genetic story of Aboriginal and Torres Strait Islander people. But the truth is, it's very different. I'll touch on that in a second. My interest in multi-omics of complex disease, so that's not just looking at the genes, but looking at all the things the genes regulate. And there's different lessons to be learned from all of those different layers. Tying all of those threads together will turn me grey. Precision medicine, how do we apply this genomic stuff to improve the care that we provide to people? Diagnosis, treatment, outcomes. And most of our work at this stage is focused on the cancer story. Now, I'm not a cancer researcher. There's excellent cancer researchers here in Queensland. I'm sure you all know who they are, Gail and crew. But there's a story to be told and work to be done about how precision medicine plays in the cancer story. We've got work to do on that front. And then this sort of emerging story about can we utilise genomics to understand this very clear relationship between healthy people and healthy country. Right, there's always talk about, like I mentioned before, the Centre for Disease Control and a One Health agenda. How do we actually, can we use genomics as a tool to understand this link, and how do we rehabilitate country? Because you can take a sample, an environmental DNA sample from a place, and work out what that place was like and all the flora and fauna that was around that place going back tens of thousands of years. So you can imagine a mining company rips out $40 billion worth of coal. How do we rehabilitate that country when it's done? Because we can't stop them doing it, it seems, in this country. Thanks, next slide. I mentioned this big diabetes study we've got going on. We started in it because we had conversations with communities about what worried us about the pattern of diabetes we saw in our communities. High burden, early onset, aggressive complications, and this cycle of intergenerational transmission of risk. So mum with type 2 diabetes during pregnancy increases the chances of that bub developing type 2 diabetes at a young age. As classically, you would think, a story that could potentially be understood with genomics as a tool. So this is the conversation we have with communities. Thanks. So we developed the prophecy study. It's the prophecy study that's now predicting renal, ophthalmic and heart events in the Aboriginal community. The community calls it the Aboriginal Diabetes Study, because why would you make up some stupid name like prophecy? It's a diabetes study for Aboriginal people. So you can come up with as many wanky names as you like. Communities will always put it up. And in a sort of classical sense, classic longitudinal cohort study, you get a whole bunch of people, you assess them for a whole bunch of stuff, and then you track them over time. We're just adding genomics into that picture. Thanks. Next slide. What are we interested in answering? Well, these are questions in broad terms that came up from our community consultations right at the start. Our response was, can we use genomics to understand and prevent type 2 diabetes and its complications? Because that's what the community wanted to know. We want to prevent it. We're sick of putting people on dialysis machines. Across that, there's then, as you can imagine, any longitudinal cohort study, there's lots of questions you can ask. These are just a sort of summary of a few key areas. What are the social, clinical, behavioural and psychological links that we see to type 2 diabetes? Is there an association with genomics or genetics across that? Can genetics help us to understand who's going to have trouble and who's not? Can they help us understand why some people seem to have a really aggressive form of type 2 diabetes, whereas others just sort of puddle along and do okay and don't ever end up on dialysis or having a heart attack? Can we stop the development of complications in the first place, etc., etc.? And the ability to apply the data that we collect across multiple levels, the use of each of that data can help us unpack some of those questions. Thanks. Next slide. We spent a lot of time before we really knew what Indigenous data sovereignty was, talking about what we were doing with data, because communities were really, they wanted to know. So as part of our consultation, we had to be really clear about the data we were collecting and what it was going to be used for, which is fair enough. This is what Indigenous data sovereignty actually is. And so we had to say, well, we're collecting this data so that we can provide feedback to the clinic. We're providing this data so that we can inform your clinical management. We want this data so that we can do these research pieces focused on these research questions. And then there may be conversations we want to have in the future about, will other people be able to access that information? At this stage, the answer to that's no. Community's not ready to send that stuff out to anyone else. Thank you. The second bit, I think the second NHMRC Synergy grant ever funded to a lead Aboriginal or Torres Strait Islander CIA was ours. The first one was James Ward. We were very proud. Is really about empowering Indigenous communities in genomic medicine. How we're doing that, exploring Indigenous knowledge systems. How do we talk about this stuff and make sense of it? Very strong focus on data sciences. How do we grow the next generation of Indigenous bioinformaticians, or at least bioinformaticians who are informed about Aboriginal and Torres Strait Islander ways of knowing and being and working? What do we understand about genetic variation? What's so cool and unique about us as people who have been here for 65,000 years plus? Our interest in multi-omics, and then a strong focus on capacity building and collaboration with health systems. Next slide. Part of this story we're starting with is, if you look at some of the family trees of European aristocracy, you would see that their family trees don't extend out broadly. They get pretty narrow because they're trying to keep their bloodlines pure. So they're all inbred. Not all. Should generalise like that. It's terrible. Whereas if you look at how Aboriginal and Torres Strait Islander people have managed the interrelationship between people, it's been very carefully thought through, it is very sophisticated, and it's likely to protect people from the development of inherited disorders, even with small population groups over tens of thousands of years with Olympics. Isn't that a better place to start talking to communities about what genomics is, with where they already understand and know, rather than saying, well, here's a machine, it goes ping, it costs $5 million, and we get some blood and we run it through and it spits out all of these letters and numbers that I can't understand, let alone how I would explain it to you. I'd much rather start with Indigenous kinship systems as a foundation for talking about what genomics is. And that work's just started. We haven't submitted ethics yet. We've been doing pre-ethics consultation for 18 months, just to talk to communities about whether or not they want to play. Thanks, next slide. And why are we doing it? Even if we don't get to do this work together, we would have spent 2 years talking to communities about what genomics is. So we'll raise awareness. We want to celebrate Indigenous knowledges. We want to build shared understanding, but ultimately the job is to empower communities to say yes or no if they want to play with this stuff. Thanks. What do we know about our uniqueness? So this is data from the National Centre for Indigenous Genomics at ANU. They've worked with 4 communities. They've worked with many others, but these 4 communities, they were able to get approval, prospective, contemporary consent, not ANU's got a whole bunch of samples that are sitting there from the 50s and 60s, which people didn't know were taken. This is not those samples. And what you look at is what's cool and unique about us. Now, what we know is from looking at our genomic architecture, about a quarter of our genetic architecture is not seen in any other population in the world. So we're unique. You'd expect that. We've been here a long time. No one's messed with us until the last 250 years. And by mess, I mean mess. But not only that, each community is unique. So about 25% of the genetic architecture you see in an actual Aboriginal community is different from an Aboriginal community that's only 50 k's away. Why is that? Kinship systems. When the first results of this came out, people rang me and they said, we can't make sense of this. Why are individual Aboriginal communities so different, so unique? It's because we're so different and we're so unique. We knew this. Anyone here who's done community consultations know you've got to talk to everyone on their own terms. They're their own bosses. We are different, we're heterogeneous. That's not just the narrative, that's actually our genetic architecture too, which reflected. And that doesn't just relate to what genetic signal you have. You can also look a little more deeply and look at the variation in the structure of certain parts of the gene, and it's the same story. Thanks. I won't get stuck on that one. The last bit of work is really how do we bring together efforts across the country. We've got an MRFF-funded national network in Indigenous genomics. Its job is to make sure that genomics delivers benefit. And so we pulled together a whole bunch of genetic folk and said, I don't care how good you think you are, I need a plan for what it's going to take to make sure what you think is really good about genomics delivers something to our community. Now, I don't expect you necessarily to have that answered, but I do want a plan. Lay it out. What's it going to take? Do we need to do this? We need to grow this workforce. We need to train people in this. We need to be able to develop reference materials and data. We need to develop polygenic risk scores. We need to develop pharmacogenomic panels that can actually work out how we metabolize different drugs. We firstly had to establish it. Our job is now to involve Indigenous people in this conversation, to identify the key policy and respond to that, to define or share or find and communicate best practice, to build capacity and very clear roadmaps to benefit. So we can talk about genomics and how cool we think it is, and we hang out with a bunch of bioinformaticians who drink Red Bull and eat, tubes all night and day while they play D&D on the side. Okay, that's cool, guys. I'm very excited for you. We've got a job. Next slide, please. Why did we develop this network? There is no critical mass in Indigenous genomics. We're fragmented. There is clearly expertise we can bring to help each other get the job done. We don't want to compete. We need more sustainable national efforts, and somebody needs to wave that flag. There is an emergence of Indigenous genomics internationally as a field, and that's a really important movement. We've got a moral and ethical obligation to get this done right. But ultimately, our job is to develop sovereignty in how we go about doing genomics for Indigenous peoples on their terms. Thanks. How does that network work? Central coordination, which we provide. We've set up these nodes all around the country, or most of the country. They each have to establish appropriate Indigenous governance. They each have to identify the priorities in policy that matters to them. They each have to let us know what's happening in terms of data, genomics data, and other related information and how that's managed. And we're going to build capacity and capability. And then we've asked each node to lead a particular roadmap to benefit agenda with the expertise that they have. In Queensland here, it's pharmacogenomics. New South Wales, precision medicine. Victoria, immunogenomics, so how your immune system functions and what we can learn from the genetic story of that. The genome biology stuff led out of ANU, and rare disease in WA. Thank you. What are we learning? Well, I've probably cracked on about this probably long enough, and I'm sure my time's up, but we've had concerns about the fairness of investing in genomics when our kids need a good, safe place to live and a square meal, a good education system, a world free of racism. So how does this agenda play out in that context? And there's no easy answers for that. There is a global push for increased diversity in these databases. I talked about the inclusion issue earlier. The question is it just pharmaceutical companies pushing for more access to new therapeutic developments? If we don't do our job, it could be. We've learned that you can't be fair without care. There are principles that guide data sharing. The FAIR principles, developed by white folk. The CARE principles are developed by Indigenous people to protect data sharing decisions with information. Who's in control? How do we protect Indigenous IP in this context? Noting full well that the Australian IP legislative framework is fucking useless for Indigenous genomics. And it may come down to appropriate contract law that we develop in partnership with communities before we start, because that might be the only provisions we have. And then how do we do this at scale if it works? Will it drive inequality if we don't do our job properly? Next. Next. Data sharing. There is clearly a sense that data sharing in many ways is inevitable. But the question is, can we control the terms by which that occurs? And we have a raft of questions. Should we share? Under what circumstances should we share data? For whose benefit are we allowed to? Did the community grant us permission to that? Did the consent form cover off on these issues? If we could, how would we go about doing that? What do we need to decide and develop? So even though there's a very strong push for data sharing across the genomics world, there's lots of other questions to work through first, and we're trying to build these sort of decision points for communities and ethics committees so that they can ask these questions themselves and make their own decisions about it. Yes. So where are we? When we started this work, which is probably only 2.5 years ago, to be perfectly honest. We've been working on that large-scale diabetes cohort for nearly 9 years. But where were we when thinking about a national Indigenous genomics agenda? No reference genome, no appetite for data sharing, certainly no interest in open access to Indigenous people's genomic data. There were some biobanks around, but there weren't really any withdrawals, so it wasn't a biobank per se. You can make a deposit, but no one was letting people take stuff out, which I think is appropriate. No investment in genetic literacy in communities. Very few clinical services that understood Indigenous interests, and no investment in capacity building. Thanks. Where are we now? We'll have a reference genome this year, which is no minor feat. We think we'll have very clear guidelines around data sharing probably next year. There is growing public trust and interest in this area, but we don't take that for granted. We have the foundations for how you could biobank for genomic efforts properly. There is growing genetic literacy in communities. Clinical services are now starting to integrate, largely led by work from Greg Pratt and colleagues here in Queensland. And we have begun, we're now training 4 Indigenous bioinformaticians. We just employed Australia's probably only Indigenous bioinformatician who was in Queensland and worked at Quake until recently. He wants to be a data nerd. So we'll help him. Next, thanks. The other question we've got, and this is a really important policy frame for genomics in Australia, what does equity in genomics look like? It's not just inclusion. We have to set the right principles. We have to invest in the right foundations. We have to have an equity research agenda in genomics that bends the wheel of genomics, not just from, hey, we can understand gene stuff, great, good for you, off you go, do it with someone else. We can apply that to reducing health inequalities if we want. And then how do you do it? How do you implement it? How do you deploy it? How do we hold the health system accountable? And how do we integrate it at scale? Where are we heading? We anticipate very clear work on understanding diabetes and cardiovascular disease from a multi-omic sense in the next few years. We're trying to develop a precision health medicine platform in New South Wales in partnership with AH and NRC. We will have national resources available for understanding genetic variation, and we want to eventually get to a point where we can trial the deployment of genomics into primary healthcare, but that's a number of years away still. As I mentioned, inclusion's one thing, it's not enough. Our ultimate objective is one of sovereignty of Indigenous people in control of their own decisions here. There's a lot of work to get to that point, but that's what we've just started. So I might leave it there. Thanks.
All right, excellent as always, Alex. Really great to see so much progress in the work, and there's so much to do still. But really pleased that you're leading it. I loved how you've blended our stories from thousands of years ago in with this, because the kinship story is really quite incredible, and the genomics of individual communities is really quite amazing. It gives us a lot to think about here as a centre. I can clearly say we're not doing any genomics work, I don't think, in the centre, but really plenty of opportunities for collaboration as we move forward. I'll open it up now for questions. So while you've got Alex here, feel free to ask any questions. Don't be shy, don't be ashamed. Victor, I can see.
Yeah, James, it seems like you're in my mind.
Yeah.
Yeah, thanks, Alex, for the wonderful presentation. While you were talking, I was just sort of reflecting on yesterday. I was at Prince Charles trying to have a chat with cardiologists that do outreach program to rural communities, and one of the things that they flagged was sort of lack of equipment, in those community clinics, which they see as a major challenge. Sometimes they have to travel with their equipment, and sometimes there could be different cardiologists going at different points in times. That continuity of care is not there. And just reflecting back on this concept of genomics, and looking at the resource perspective within these communities, and how this could be integrated in such difficult circumstances. And the other thing was also what you foresee as the opportunities and maybe challenges in probably upscaling this to a more like a population level.
Yeah. So all really, really great insights and questions. The first is, so I've been involved in cardiovascular health for the last 25 years, and I've heard every reason under the sun from cardiologists why they can't do a job. So, we can't get release from our host institution hospital because we'll go to a community that's not covered under that referral filter. We don't have qualified ultrasonographers to do cardiac echoes or ultrasounds. There's no workforce continuity in the remote clinics, so no one arranges all of our clinic times. Patients don't turn up. We don't have the right flights. We've heard it all, right? The reality is, now, not to be sort of generalising, but most of the cardiovascular community in Australia doesn't give a rat's about Black people. Now, we're not going to help them earn their $1.5–2 million a year, right? So it's the rare cardiologist who will commit their entire life to providing outreach services, and that's probably not just in cardiology. We would see that in a lot of different areas. In terms of the equipment side of things, most clinics are set up with point of care instruments that can give you most of what you need for a cardiovascular risk assessment. Right? James has been involved in the development of those programs of work in the STI sense, but they're the same. It's the same architecture for cholesterol and hemoglobin A1C and urinary ACRs. So you can do most of that with a point of care. You can now do echoes, enough that you would need on an iPhone, right? So you can plug in an ultrasound, almost ultrasound probe into a phone and get an image. Right? So that stuff's now done. The bigger challenge is the investment in an Aboriginal workforce, which none of the hospitals will do because they're often not in their remit or interest or local hospital district. They don't leave anything behind. They fly in and fly out to a place they like to visit and actually don't invest in local community and workforce. So that's probably the bigger challenge. In terms of how do we think genomics could be integrated in primary care? So I say it's a very expensive proposition, right? The genomic sequencing side of this story now is cheap. So we will be, within the next 5 years, down to a point where a sequence, the first sequence cost $1 billion. I don't even know how much that money is. It's now at under $1,000. We expect in 5 years it'll be $100 for a genome sequence, right, top to bottom. Now, that's cheaper than some X-rays. And the thing about a genetic sequence, you only need to do it once because it doesn't change. So that's affordable. That's actually affordable in the Australian healthcare system for every single person. Now, do we do that? I don't know. But the bigger question is, what do we do with that data? How do we store that data, analyze that data? How do we communicate with the patient and the family about what that test is about and what it means and what it might show and what we need to do about it? How do we communicate what we found and what it means, not just for that patient, but if they've got something that's genetic, do we then have subsequent conversations with the family? And how do we do that properly? Do we have a genetic counselling workforce to do this? No, absolutely not. We're probably short 5,000 to 10,000 genetic counsellors in Australia, let alone genetic counsellors in Aboriginal health. We know of 3 Aboriginal genetic counsellors in the country, and we're working with all of them, and that's it, total. So the bigger question is how we would do it in terms of models of care, workforce, and integration within the way in which we work. The technology bit's probably easier for genomics. The analysis applications would be in things like risk. So we do the framing and risk equation for heart disease. We've now moved to a new risk equation. It's probably a bit better, but it's been tested. Does knowing our gene story help us do that? Probably, but we're going to have to build it. And given the uniqueness across communities, where they're all different in certain ways, does that matter in terms of that? And then we've got the polygenic risk, the pharmacogenomic panels to know Aboriginal people in this community don't respond as well to this therapy, we should probably change. They're the most likely and immediate applications within primary care, and I think within the next 5 to 10 years. So that's what we're planning at. So it'll be genomic sequence integrated into electronic health records, immediately informs risk prediction, and we'll have a lifelong, pharmacogenomic screen to say, don't give them warfarin, don't give them aspirin, don't give them this particular barbiturate because it'll make them really sick. I think that will happen soon. Sorry, it was a very long answer. I was just trying to cover off all the bits.
Sorry, we have a question in the chat. I can read it out if you'd like. This one's from Jean. She said, thanks, Alex. Have you got any comments about working towards a more explicit approach to consideration of equity in the PBS, MBS funding processes?
Well, I assume that's not specifically relating to genomics, which is okay. The problem, James has been on these panels, I've been on these panels. Mark Wennerton spent half of his life on these panels. The way in which equity is considered within access to pharmaceuticals in particular, and specifically new pharmaceuticals through their PBAC process, is profoundly problematic. The other thing is that whole system is built on a drug model, not on a healthcare delivery model. So if you had a model of care that should be covered under MBS, how do you get that into the system to make sure that it's included? Now, the renal dialysis for remote Aboriginal patients, MBS item, took 15 years worth of work. And I don't even know how they ended up getting it across the line, to be honest, but they have. You've seen what successive governments do with sort of, the MBS items for psychology services. It started at 9, it increased to 10, was all used in the North Shore of Sydney, so obviously nobody else in the country needed to talk to anyone about their psychological well-being. Only the people in Mossman, the psychologists in Mossman did a really good trade. Everyone else got screwed. So then they canned it. Then there was a fun fight about it, so it's reinstated, right? So unfortunately, a lot of these instruments are not considering equity ever, and are not built for purpose for the healthcare in a holistic sense that we understand and focus on as, say, Aboriginal and Torres Strait Islander people, as opposed to the pharmaceutical company that wants to sell a drug that's used in Clinic X. Equity does not really live in Australia. That's the truth of it. And despite 20 years, we've been fighting for equity, having equity in every conversation we have, in every policy setting we've ever been in, we're still not winning that battle. I think the fundamental reason is most people don't care. Most people don't care about equity. And that's why we have the jobs that we have, because we have to continue the fight forever until our last breath. Because no one's listening if we're not fighting. So I'm sorry, I don't have any miraculous answer to that question beyond push on. We can't give up.
Okay, any other questions?
Just quickly, just to pick up, Alex, on your point about that genetic testing. I mean, already we have to go over this, but there's the issue of identifying, issues in the genome purely for insurance purposes. So we need to sort that out in Australia, because otherwise no one's going to go and get tested because they'll be too scared. But the question I wanted to ask you: did I hear it properly that your initial results already look like there may be fewer problems in Indigenous genomes, DNA, than there is in European?
Well,
I know it's early days, but
no, it's very early days. It's a great question.
Yeah.
Very important question. First, with the insurance side of things, there's been now the release of a discussion document to extend the moratorium on insurance companies using genetic results as a form of discrimination. So if you guys are ever asked to comment on that, have a read, but I think we should all fight for no discrimination on the basis of your genetic code, whether you're black, white or green. And that's been a strongly held and supported view from the genomics community. So they've been really good about that, I have to say. That then leads into questions about ancestry and, 23andMe and what have you, sort of questions. None of those kits will work for us as Aboriginal people because there's so few Aboriginal and Torres Strait Islander people in the database to make a call on your ethnicity, your background, your ancestral diversity. We'll just touch on that. The last bit was...
what I was wondering, whether if it looks like there's more, I don't know what the words are.
Europeans.
Yeah,
we blame Europeans.
Yeah.
Yes, let's do that. Mongrels,
That's fine.
they're a bunch of mongrels. We are perfectly equipped as Aboriginal and Torres Strait Islander people to survive this landscape for tens of thousands of years, right? This does not happen by accident. So ultimately, do we think that there is particular elevated risk of disease because of European impacts on Indigenous Australians, whether that be genetic or social? We think so, but we don't have the smoking gun on that. I look forward to the day where I can actually say that credibly at a large press conference and blame a whole bunch of white people for what I said. No offence to anyone in the room. I'm being a little bit glib about that. What I was suggesting is we don't live here for so long healthy and well without having a system and biology that is perfectly adapted to this place, because we would have died. Right? No one survives that long without having some good shit sorted out. So I think that's a really important narrative of strength that we can use. The other piece is whether or not those wonderful biological foundations that we had when exposed to a whole bunch of toxic external pressures that came in 250 years ago, was that the perfect storm for many of the troubles that we see now? And that's what we're trying to unravel. Now, I'm not trying to unravel that to point the finger at white folk. We're trying to unravel that so that we can look at mitigation. So how do we stop that impact of toxic external environments utilising a genomic, or probably what's most likely an epigenetic response? That's the challenge. That's why the environment and gene story is going to be so important.
Yeah.
Thank you. It's a great topic and great presentation. My background is not genetics, obviously, but I think I have a couple of technical questions. From understanding the risk score, polygenic risk score, I guess we are also relying to the GWAS data from other populations. So because we don't have really the GWAS data for the indigenous population, either in Australia or globally. So I guess then the genetic risk score is how reliable it is. And then also polygenic risk score is not really giving any specific information for precision medicine. It's giving some broad information. So this is one thing technically. And other thing is, I guess, what we have so far is probably 200 people genetic data. So are we planning to expand that and make it bigger?
Very good questions, thank you. So polygenic risk scores, absolutely built on the basis of larger European populations. There are now polygenic risk scores that have been derived across multiple ethnic groups. So there's now polygenic risk scores that include African populations, some Southeast Asian populations, but none have included Indigenous people. Now, the data I put up on one of those slides was the accuracy of all of those polygenic risk tools are much lower applied to different population groups. There are people here in Queensland at UQ. One just got a Snow Fellowship, Loic, an African chap who is working on how you can make polygenic risk scores more portable so that you can take this polygenic risk score and modify it to a way that can be used in that population. So we will get better. The problem is most of these polygenic risk scores increase your chances, so increase your risk by a factor of 10%. But we don't get out of bed for a risk ratio less than 2, right? Because you want to make it core public health business, an increased odds ratio of 0.1, it's really not enough for me to change clinical or population health practice. So they're not good enough yet. They're not privatised for that reason. And that's an enormous challenge. Where it seems to be most useful, certainly in the context of cardiovascular disease, is people who turn up on a risk score that you would normally do on clinical and easily identifiable information, and they end up in this intermediate zone, right? So for premium risk, you've got low risk, you've got intermediate risk, you've got high risk. You can apply a polygenic risk score if they've got sequence data on that intermediate risk, and it helps to separate people out much more accurately. So there'll be polygenic risk scores used in particular clinical and population health circumstances. So that's where it is now. The second component was, are we looking to expand? Yeah. Look, we are, but there's no rush on that because I think that we've got work to do, particularly around this benefit conversation and to prove that genomics can be useful so that we're going to communities outside of the communities we're working in South Australia and saying, well, this is what we've shown, this is how it could be used, this is its accuracy, this is how it could provide benefit to you, your call. So I'd much rather have something in my hand rather than a promise, because I can't sell hype except to a grant review panel. I can sell them some hype, but for communities, they've got a much stronger bullshit detector, as they should. and we've got to actually prove what we're up to. But yes, we would love to have those conversations about it.
Can I ask one more question?
Well, that's it now.
I'm fascinating about all this. Really. I guess you have a lot of information, proteomics, genomics, all this. I'm not sure that you have information about also gut microbiome.
Yeah, so
And there are lots of contextual information. So if you are using all of them, there could be some AI that can really predict cardiovascular risks or other things probably more precise way than the usual traditional modeling approach.
correct. So yes, we've collected a lot of shit, but we haven't collected shit. We couldn't. So community said no. Fair enough. I didn't really want to be taking those samples myself either. But you're right. I mean, it's a really important layer. The problem is with the microbiome stuff thus far, it's a bit like vitamin D. Right? Vitamin D is associated with everything. So it probably means it's not associated with anything. And it's like saying, well, every human breathes oxygen, every human dies, oxygen kills people. Right? So there are so many variables in microbiome research about how do you control for diet, and how do you control for recent antibiotic use, how do you control for vaccine delivery and vaccine responsiveness, how do you account for the household in which people live and exposures that you have there and where you walk and how much sunlight. So they haven't sorted all of that out yet, and that's the great challenge with microbiome research. The next challenge is, even without that, how do we integrate all of this information? The problem is, we actually don't know what information is going to be really useful. So we've collected everything, and it may be that collecting all this genomic information doesn't help us any more than what we already can do by doing a physical examination of a patient and taking some blood. But we don't know that yet. So we're going to put that to the test, clearly. We have unanswered questions of the biology of things like type 2 diabetes that maybe genomic can be a tool to help us unpack. But it might be that we've collected 27,000 variables, and if we want to accurately predict risk, there's only 5 things that you really need to know. The only way that we're going to be able to actually work through that will be with machine learning approaches. The challenge with AI and machine learning approaches is most of the algorithms are fundamentally racist, and they don't know it because they're not sentient. So they don't know they're racist, so they just think, hey, we'll just run this stuff and we can see all this bullshit. And then they spit out an answer. Most of the algorithms are built on an architecture that is racialized because that's where it gets its information from. So we've got enormous challenges. The good thing in when you've got all this data, you're just training the algorithm on the data that you have, not on what the world produces across the internet. That being said, communities are still nervous about this stuff. And we haven't even started those conversations about risk prediction using AI and machine learning, but that's where we'll end up.
Thank you.
Definitely.
I've got 3 rapid fire questions, but I won't do them. I'm very interested in countries' genomics and and that connection to One Health. I'm very interested. What happens if we find a gene that's unique to Aboriginal people that's amenable to a new treatment, and the drug companies make $5 billion a year off it? How do Aboriginal communities benefit from that? And I'm very interested in primordial prevention using precision or using genomics for prevention of disease, and how far we are along in that pathway. I mean, yeah, balance is probably at the other end, precision medicine to fix rare diseases, but yeah, how far are we away from those 3? They might be very long answers, but they're my 3 rapid fire.
Yeah, extremely good questions. Primordial, we should absolutely work through that.
Yeah.
We are nowhere near it, and that's our job is to swing the pendulum back.
Yeah.
I think the STI space, particularly vulnerability and likeliness of transmission subsequently, may be an area where pathogen and host genomics could be useful. We can talk about that. How do we protect the rights and interests of Indigenous people in the event of a gangbuster drug? I don't sleep at night thinking about that. And that's the great concern. It's like, how do we protect that interest? IP doesn't work for genomics because as soon as your blood is taken, but we all say, oh, you know, Indigenous IP needs to be protected in genomics. As soon as that sequence is done, it's no longer your IP, even though we culturally would think very strongly that that is our IP and our family's IP and our ancestors' IP. But the Australian legal system doesn't account for that. That's why I mentioned contract law. We've got to get really good at the front end negotiations with communities about if we return anything, if this is commercialised, what's your cut? And what does that look like? And we do it in contract law. And if pharmaceutical companies won't sign on that contract, it doesn't get done. Are we in a position to develop a genetic variant into a therapeutic? Well, I'm not. I can barely spell DNA, as you know. So I'm not a geneticist either. But this keeps us awake at night. And we're so worried about it. And the first rapid fire?
The genomics of country and restoration.
Yeah. Extremely cool. The context here is genomics is not the end. Genomics is the tool. And I think getting that across is going to be really important. I think this healthy country piece, environmental DNA, historical DNA, ancient DNA of country is something we can use to understand what kept us healthy and strong for so long. Watch this space.
Yeah, definitely. All right, I think we might wrap it up there, but thank you, Alex, for taking time out today, coming and visiting. It's good to catch up, and we'll be all in touch. And fantastic presentation as always. And thanks to everyone online as well. Thanks for your comments.